Hi everyone. Today I'm going to talk to you about an initiative that we implemented in the Western New South Wales LHD, which we refer to as RVAC, or Remote Video Assisted Chemotherapy. Now I've got to work out how I'm doing this. Got it? Okay. So a bit of a background to our initiative. It is well reported that for people living in rural Australia, they do have poorer health outcomes. Now, some of this is due to geographical isolation, social economic disadvantage, shortage of healthcare providers, lower levels of access to health services, greater exposure to injury risks. And it's actually stated that the life expectancy for people living in rural Australia is 2.5 times less than those living in metropolitan areas. Okay. What we found within our LHD was that people weren't having treatment due to the distance required to travel to access specialist healthcare. Now, some of these reasons were costs, and some people in our area actually have to travel 4 to 5 hours one way to get their treatment or to see a specialist. So our oncologist, Dr. Florian Honeyball, had heard of a telehealth model in Queensland, which referred to as the Queensland Remote Chemotherapy Supervision Model, and thought it was a great idea that we implement something like this within our area. Okay, basically in towns, the Queensland model is used in Townsville and it supports areas of Mount Isa and Thursday Island. Now, telehealth wasn't a new thing in the district and had been used in the district for many, many years. In oncology, we started using it in 2013, where our oncologists used telehealth to complement face-to-face patient consultations to reduce travel for patients. And in 2017, we implemented what we refer to as RVAC, where low-risk, low-toxicity treatments would be administered using telehealth. Our aims of the project were to improve cancer outcomes for people living in small communities by using telehealth to supervise the administration of cancer treatments. Okay. Also to deliver treatment to patients closer to home, which I think, as we can tell, was a bit of a focus earlier this morning. What did we do? Okay, we went up and had a look at the Queensland model. Dr. Honeyball and a few representatives from our area went up and observed how they actually did their remote chemotherapy and really enjoyed that. We did an analysis in our community to see what communities would benefit, okay? In that analysis, we looked at things like what support would be available from local GPs. So part of the model in Queensland was that there was a local GP available on the days that chemotherapy was being administered, just in case their assistance was required. We also had to look at suitable facilities, so an allocated space that we could call our own within the health facility, and also work health and safety concerns as well, like an emergency shower if needed and things like that. We had to get commitment from local management. I think, as we also heard this morning, getting local management on board is a big thing in any health district to actually implement a new process. We also had to look at suitable nurses. Okay, what nurses could we use? Being in a rural area, the nurses are very well trained in a diverse range of backgrounds, but they're short. There's shortage of nurses in rural areas. So we had to look at what nurses we could get. What we actually chose for the project was nurses with an acute nursing background. Even though the nurses we currently use are community nurses, all of them have had acute nursing background. What we found with that was that the nurses were used to things like the IV pumps. They had great cannulation skills, identification of deteriorating patients through between the flags, time management in a clinical area. So we really found those as beneficial when we're selecting our nurses. Also the delivery of treatments and supplies. So how could we get that chemotherapy delivered to Coonabarabran, which is the place we chose for this pilot, and the supplies that we needed in a timely manner and a safe manner. Okay, had to identify what treatments were we going to give, and I'll go through that list shortly. Okay. The procurement of equipment. So we had to set up with some chemo chairs. We had to set up, get fridges. We had to get quite a lot of equipment for that, which we were able to gain funding through a pharmacy grant, which was fantastic. Then we had to look at training the nurses. So nurses in the rural community and also the nurses in our hub site of Dubbo also had to be trained. Our RVAC nurses, the guys in Coonabarabran, were trained to be what we call, thank you, chemo safe, not chemo competent, okay? And I can explain that to you further if you want to come and talk to me about that. But the training involved doing the ADAC modules, okay, through Everq, and then they'd come to Dubbo for 3 days to consolidate their learning and also be assessed. The Dubbo nurses needed training in the processes of RVAC, so what was going to happen, who was going to do what and whose roles were what. Also the use of telehealth, so they became familiar with that model. The results, okay. So we're doing it currently in one country town called Coonabarabran, which I'm not sure if anyone knows where that is. I know there's one person from Coonabarabran here, so she definitely knows where that is. 1 day a week. So we started in October 2017, and till August this year, we treated 205 treatments, 26 patients in total, okay? 820 hours were saved in travel time for these patients, and that's at a minimum because some patients still travel to Coonabarabran to get their treatment. It equates to approximately 68,000 kilometres. Okay, so a trip to Coonabarabran, a round trip from Coonabarabran to Dubbo is about 330 kilometres, or about a 4-hour round trip. Some of the implications. So as I said before, the low risk treatments, okay? So some of the treatments that we've used in Coonabarabran were administered immunotherapies, your fluorouracil, irinotecan after a few cycles in our hub site of Dubbo, your gem, methotrexate, your MABs after a few cycles in Dubbo, your Exgevas, your Zolidexes, your ports and picks flushes and dressings. Intravescular treatments is a big one that we're actually doing, and we do that weekly, at least one a week there. And paclitaxel after 3 cycles in Dubbo, where the risks of hypersensitivity reactions is lowered. Expiry time of treatments, which I already touched on as well. So we actually had to look at the expiry time. So drugs with a short expiry obviously couldn't be administered due to logistics there. And going on to my next point about logistics of getting treatments there. So we use a compounding pharmacy in Sydney where our treatments are delivered to Dubbo. Then getting those then freighted out to Coonabarabran in a timely manner, ready for treatment, was a thing we had to look at. Training of the nursing staff, already discussed on that a little bit, but one of the things I found is not to train too many nurses. I mean, this is a 1 day a week service that we're giving to Coonabarabran. Too many nurses trained will indicate that, you know, not everyone's going to get a turn and keep their skills up to speed. And that's the same within our Dubbo site. So we currently have 2 nurses trained in supervising RVAC, Marnie, who's here. Wave your hand, Marnie's there. So Marnie will talk to you later if you want to talk to Marnie as well. Marnie, and then we've got someone else trained for when Marnie does go on leave, okay, or is needed somewhere else within our service. Knowledge of patients receiving treatment. So our community nurses have found it's really increased not only their skill, but also the knowledge that they've got about what treatments their patients that they're looking after in the community are receiving. And it's really building that, that connection with their patients. Okay. Rostering of the nurses, I think I've already discussed that to somewhat, but it's also increased our chair availability in Dubbo. So by giving treatments in Coonabarabran off-site, Dubbo unit at the moment, while we are due to expand shortly, we have 8 treatment chairs, and we've actually had to recently expand our hours of service for the increased need in those chairs. Thank you. Okay, outcomes. Look, I think the best way to find out how this has gone and everything is to sort of get some quotes from people themselves. So Crystal Harper, who is also here today and would love to talk to you if you'd like to talk to her. These are Crystal's words. It's had a huge impact on my life and has given me back my independence. I can get myself to and from treatment without needing to rely on other people and services. It has saved me time and money. It's also allowed me to enjoy daily activities and enjoy my life. Okay, some input from a nurse. The RVAC program has provided Coonabarabran clients, loved ones, friends and community with a chance of hope, a chance of survival. Our clients have stated that if RVAC was not available in Coona, they would probably not travel for their treatment due to the burdens of travel and fatigue. As an RVAC nurse, it gives me great privilege to be able to offer this service to our community, and it does put a smile on their dial. Okay, that's all that I've really got to say. Time's up. There you go. Thank you.
Okay, well, great timing. We have time for 1 or 2 questions. So I think we have a roving microphone, or maybe just stand up with a very loud voice. Does anyone have any questions they would like to ask about the project? Yes, down the front. Yes, microphone is coming. Taryn's getting her exercise today.
Thank you. I'm Heather from Griffith. How long did it take to implement it?
From when we went up to Queensland to actually implementation, it was probably around about the 6 to 8 month mark. That said, though, it was delayed due to the fact that Coonabarabran Hospital had a bit of a flood and needed to actually have some renovations beforehand. So watering system or something ruined all the plaster in the walls and had to be fixed. So that was our delay. Anything else?
Thank you very much. I'm sorry if I missed the answer to this question already, but who was on the other side from Dubbo's end that they were videoing with, and how, were they there for the whole time?
Yes,
or just
definitely, yeah. So basically, our most senior nurses are on the other side in the Dubbo end. So they're there to assist the nurses and to watch them. And with the telehealth facilities, we can check our drugs. So we actually use Type VNC to actually log on, and because we use an EMR as well. So we'll actually double check the drugs through that, and basically you can put the bag of chemo or treatment, whatever it may be, against the screen, and you can see everything that's on the bag, the label on the bag, to the IV pump rates and things like that, to the cannulation site, you can see everything. So yeah, but yeah, our most experienced nurses, and they are there all the time. I recently sat in on this week's due to some other reasons, but yeah, and it's great. And one of the patients this week said, "Oh, this beat's coming to Dubbo," which, you know, you sort of take a bit of offence to, but you're happy for them.
Hi, my name is Oksana. I'm from Cancer Institute. When you implemented this program, did you also implement some sort of routine distress screening for the patients undergoing chemotherapy?
Yeah, so all our patients are reviewed by the oncologist prior to each treatment by telehealth as well, and they also have had experience with us. They've got access to our counsellors, and with the distress screening, it's probably not something that we have fully implemented in our area, but we are looking at doing that at the moment and, yeah, introducing that. So not quite yet, but getting there.
Okay, well,
Thank you.
I think we'd all like to thank Cherie again.
Thank you.
Thank you very much for coming. That was wonderful.